Most people think the first sign of dementia is forgetting names, forgetting where you put your keys, forgetting what you had for breakfast. But what if I told you that for a significant number of people, people in their 50s, still working, still raising families, still fully in the middle of life, the first sign has nothing to do with memory at all? What if the first sign looks more like a personality change, a sudden obsession with a new food, an inexplicable loss of empathy for the people they love most, or an inability to stop repeating the same phrase over and over in conversation? What if the brain disease most people have never heard of is actually one of the most common causes of early dementia, and the reason it goes undetected for so long is because it doesn't look like what we've been taught dementia looks like? Stay with me, because what I'm about to share with you comes directly from the National Institute on Aging, one of the most credible health research bodies in the world. And there's one detail, about 2/3 of the way through this, that I think is going to genuinely surprise you. Let's start from the beginning. The brain disease we're talking about today is called frontotemporal dementia. You may have heard it abbreviated as FTD. You may never have heard of it at all. And that's actually part of the problem. For decades, this condition has lived in the shadow of Alzheimer's disease. When people think of dementia, they think of memory loss. That's the picture we've all been given. And for Alzheimer's, that picture is largely accurate. But frontotemporal dementia operates completely differently. It targets different parts of the brain. It shows up with different symptoms. And it tends to strike at a very different age. Here's a number that stopped me when I first read it. Roughly 60% of people diagnosed with frontotemporal dementia are between 45 and 64 years old. Not 80, not 75, 45 to 64. That means this is not primarily a disease of old age. It's a disease that can arrive when you are still in the middle of everything. Your career, your marriage, your relationships with your kids, your plans for retirement. It arrives quietly, and it often disguises itself as something else entirely. So today, I want to walk you through what frontotemporal dementia actually is, how it actually behaves in real people's lives, what the research tells us about its causes, and, most importantly, what you can actually do with this information. Not to frighten you, but to give you something most people never get when it comes to brain health: clarity. Let's talk about where this disease lives in the brain, because this is where everything else starts to make sense. Your brain has different regions that control different functions. The frontal lobes, sitting just above your eyes and behind your forehead, are responsible for what scientists call executive functioning. That's the part of your brain that plans, prioritizes, makes decisions, manages impulses, and helps you navigate social situations appropriately. It's the part of your brain that knows it's not appropriate to shout in a quiet room. It's the part that helps you pause before you react. It's the part that lets you think 3 steps ahead. The temporal lobes sit lower, to the sides of your head, on the left and right. These regions are deeply involved in language, in understanding words, connecting meaning to objects, and regulating emotions. They help you recognize a face and feel the right emotion in response. They allow you to read, write, and follow a conversation. Now imagine that a disease begins attacking these 2 regions, quietly, gradually, while leaving the memory centers of your brain largely intact, at least in the beginning. What would that look like from the outside? Here's where most people get it wrong. They assume that because memory seems fine, the brain is fine. But in frontotemporal dementia, memory can remain relatively preserved, even as the person loses the ability to plan, feel empathy, control their impulses, or understand language. This is why the disease so often gets misdiagnosed, and why families sometimes spend years thinking the person they love is simply being selfish, difficult, or depressed. The National Institute on Aging is direct about this. Symptoms of FTD and related disorders are often misunderstood. Family members and friends may think a person is misbehaving, leading to anger and conflict. It is important to understand that people with these disorders cannot control their behaviors. That sentence matters. Cannot control, not won't control, cannot. And I want you to hold on to that, because when we talk about what the behavioral changes actually look like, that distinction becomes everything. The most common form of this disease is called behavioral variant frontotemporal dementia, And the name tells you exactly what it does first. It changes behavior. It changes personality. It changes the way a person moves through the world. Someone who is warm becomes distant. Someone who is cautious becomes impulsive. Someone who followed social rules without thinking now says things that are startlingly inappropriate. In a store, at dinner, at a funeral, and seems completely unbothered by it. Not defiant, not deliberately hurtful, just genuinely unable to register that anything unusual has happened. Some people develop compulsive eating behaviors. They might take food off other people's plates without thinking. They might develop a sudden fixation on a particular food they've never cared about before. Some people begin repeating the same word, the same phrase, the same action, in loops. And here's what makes this so particularly heartbreaking for families. The person with this form of FTD often lacks awareness that anything is wrong, not because they're in denial, but because the part of the brain that would generate that awareness is the part that's being affected. Insight requires a functioning frontal lobe, and when the frontal lobe is compromised, the capacity for self-reflection goes with it. So the family is watching. They're confused. They're hurt. They're wondering what happened to the person they knew, and the person at the center of it all is, in many cases, entirely unaware. This next detail changes everything when it comes to how we understand early diagnosis. Because there's a second major form of this disease, and it doesn't show up in behavior first. It shows up in language. It's called primary progressive aphasia, and it involves a gradual, progressive loss of the ability to communicate. Not suddenly, the way a stroke can affect speech. Slowly, incrementally, over months and years. There are different patterns within this form. In one, a person slowly loses the ability to understand words, even familiar words, and sometimes loses the ability to recognize faces they should know well. In another, they have increasing difficulty actually producing speech, stumbling over words, leaving them out, until eventually speech may stop entirely. In a third pattern, the person knows what they want to say, can understand what's being said to them, but cannot find the words when they need them. For someone who values conversation, who has always expressed love through words, who connects with grandchildren through storytelling, this is a profound loss. And because it starts small, it's easy to dismiss. An awkward pause, a word forgotten mid-sentence, a moment of confusion that seems like fatigue. The research from the National Institute on Aging is careful to note that problems with memory, reasoning, and judgment are not typically apparent in the early stages of primary progressive aphasia. They can develop over time, but by then, years may have already passed. Which brings me to something I want to say clearly, because it matters. One of the biggest barriers to early identification of this disease is that it looks like other things first. Behavioral variant FTD is sometimes misdiagnosed as depression, sometimes as bipolar disorder, sometimes as a midlife crisis. Primary progressive aphasia might be chalked up to stress, anxiety, hearing loss, or simply getting older. And because frontotemporal dementia is less well known than Alzheimer's, even some physicians may not immediately recognize what they're seeing. A person can spend years going to the wrong specialists, receiving the wrong treatment, feeling confused and dismissed, while the underlying cause goes unaddressed. And this is why it matters so much that you know this exists. Not to diagnose yourself or someone you love. That's a doctor's job, and we'll come back to that. But to know the questions to ask. To know that if something feels wrong, if someone you love is changing in ways that don't make sense, there's a reason to dig deeper. Now, we're about 60% of the way through what I want to share with you today, and this next part is genuinely the most important. I want to talk about what actually causes this disease, because this is where the science gets fascinating, and this is where you'll understand why some families seem to be at higher risk, and what that means in practical terms. At the cellular level, frontotemporal dementia is associated with the abnormal buildup or malfunction of specific proteins in the brain. Two in particular, tau and TDP-43. These proteins exist naturally in the body. In healthy brains, they play important roles in keeping nerve cells functioning properly. But in certain people, for reasons researchers are still working to fully understand, Something goes wrong with these proteins. They don't fold correctly. They accumulate in ways they shouldn't. And when that happens in the frontal or temporal lobes, neurons, brain cells, begin to die. The brain itself shrinks in those areas. This shrinkage is called atrophy. It can be seen on brain imaging, which is one of the tools doctors use to investigate what's happening. Now, here is the part I promised you. An estimated 1/3 of frontotemporal dementia cases are inherited. That means the tendency is passed genetically from parent to child. Researchers have identified specific genes that, when they carry certain mutations, significantly increase the risk of developing this disease. One gene, called MAPT, affects the tau protein directly. A mutation here means a person will almost certainly develop some form of frontotemporal disorder, though the exact age and type of symptoms cannot be predicted in advance. Another gene, called GRN, can lead to reduced production of a protein called progranulin, which in turn causes TDP-43 to malfunction inside brain cells. What's particularly striking about this gene is that the same mutation can cause noticeably different symptoms in different members of the same family, and the disease can begin at different ages. A third gene, called C9orf72, appears to be the most common genetic abnormality found in inherited cases of both frontotemporal dementia and ALS, also known as Lou Gehrig's disease. Now, I want to be precise here, because I think precision matters when we're talking about genetics and family health. Having a family member with frontotemporal dementia does not guarantee you will develop it. Genetics is one factor among many, but it does mean that a family history is clinically significant and worth discussing honestly with your physician. For families where there is a clear inherited pattern, genetic counseling and genetic testing are options that exist. These conversations can feel difficult. They can bring up fears that are completely understandable. But knowledge, even difficult knowledge, gives you choices that ignorance doesn't. Let's talk for a moment about the other forms of frontotemporal disorders, because they are rarer, but they matter, and they share something important with the conditions we've already discussed. They are often misunderstood and often misdiagnosed. Two of these are movement disorders. The first is called corticobasal syndrome. The primary difficulty here is with movement, not because of muscle weakness, but because of a loss of the brain's ability to coordinate voluntary movement. A person might struggle to button a shirt, operate a simple appliance, use their hands in ways that used to be automatic. One or both sides of the body may be affected, and the symptoms tend to progress gradually. The second is called progressive supranuclear palsy. This disorder typically begins with problems in balance and walking. People may move slowly, experience unexplained falls, develop a fixed facial expression, have stiffness in the neck and upper body. There is also often a very specific and distinctive difficulty with eye movement, particularly looking downward. Both of these conditions can also affect thinking, language, and behavior over time, which is why they fall under the broader umbrella of frontotemporal disorders. There is also a form called FTD with ALS, a combination of behavioral or language changes alongside the progressive muscle weakness that characterizes amyotrophic lateral sclerosis. This is a particularly challenging form of the disease because it presents on two fronts simultaneously. I am sharing all of this not to overwhelm you, but because one of the most consistent findings in the research is that these conditions are underdiagnosed and misdiagnosed. And one of the reasons they're misdiagnosed is because people, including healthcare providers, haven't been exposed to the full picture. You now have more of that picture than most people do. So let's talk about what to actually do with it. First, if you have a family history of early dementia, personality changes, language difficulties, movement problems, or ALS, especially in people under the age of 65, that history is worth documenting and sharing with your doctor. Not in an alarming way, just as a matter of informed care. Your doctor can help assess whether further evaluation or referral to a specialist makes sense. Second, pay attention to changes that don't fit the usual narrative. If someone you love is struggling with language in ways that seem unusual, or showing personality or behavioral shifts that don't match who they've always been, trust that feeling. Ask about it. Bring it up to a medical professional. You are not being alarmist. You are being attentive. Third, Know that diagnosis of these conditions involves multiple tools: a thorough examination, detailed personal and family history, neuropsychological testing, assessments of behavior, memory, language, and thinking, brain imaging, including MRI and potentially PET scans, laboratory tests, sometimes genetic testing. No single test tells the whole story, but together, these tools can build a picture. Fourth, and this is important, be patient with the diagnostic process, and if needed, advocate for a second opinion. Because FTD can look like depression, like other dementias, like psychiatric conditions, getting the right diagnosis sometimes takes time. Finding a specialist at a medical center with expertise in frontotemporal disorders can make a significant difference. And fifth, if you are caring for someone with this disease, please hear this clearly. The behaviors that feel hurtful, the apparent indifference, the inappropriate comments, the repetition, the changes in personality, these are symptoms of a disease process. They are not a reflection of how much that person loves you. They are not a choice. The brain regions that regulate empathy, impulse control, and self-awareness are compromised. Your grief over who they were is real and valid. And the love that existed between you is also real. Even when the disease makes it hard to see, caregiver support matters. Connecting with others who understand what you're going through matters. There are organizations and clinical specialists who can help navigate both the practical and emotional dimensions of living with this disease in a family. I also want to say one more thing before we close. Research on frontotemporal dementia is advancing. Biomarkers, substances in blood or cerebrospinal fluid, are being studied as potential tools for earlier and more accurate diagnosis. Brain imaging is being refined. Genetic research is illuminating the mechanisms at work, and scientists are searching not just for better diagnosis, but for treatments that can one day slow or stop the progression of the disease. There is currently no cure. There are no treatments that reverse what has already happened. But there are ways to manage symptoms. And there is reason to believe that the progress being made in research today will translate into better options for future generations. Families affected by inherited forms of this disease can actually contribute to that progress by participating in clinical research. If that's something that feels meaningful to you, speaking with a specialist or visiting clinical trial registries like Alzheimer's.gov is a place to start. As always, nothing in this video is a substitute for personalized medical advice. Every person's situation is different. The information here is meant to inform and empower, not to diagnose, not to alarm, not to replace a conversation with a qualified clinician. Please bring your questions to your doctor, and if your concerns aren't being heard, keep advocating until they are. Here's what I want you to take away from today. Frontotemporal dementia is real. It's more common than most people realize. It often strikes earlier in life than other dementias. It doesn't always look like memory loss. It can look like personality change, language difficulty, or movement problems. A meaningful portion of cases have a genetic component, and it is frequently misunderstood by families and sometimes by healthcare providers. Knowing this does not mean living in fear. It means living informed. And informed people ask better questions, seek help sooner, and advocate more effectively for themselves and for the people they love. Aging is complicated. The brain is complicated. Anyone who tells you otherwise is oversimplifying. But complicated doesn't mean hopeless, and it doesn't mean you are powerless. You came here today because you care about your brain, your health, and the people in your life. That instinct is exactly right. In the next video, I want to talk about something that is deeply connected to everything we discussed today. The difference between normal cognitive aging and the early signs that something else may be happening. Because there is a difference, and learning to read those signs clearly, without panic and without denial, might be one of the most important things you can do for yourself right now. If you want to keep aging with clarity, with strength, and with real information, not fear, not confusion, subscribe. Because that's what we're building here, one honest conversation at a time. Thank you for watching. Take care of yourself and take care of the people around you.